Hello, everyone, and welcome back to CleanMedKE, your go-to resource for clear, high-yield medical education. I'm your host, and today we are diving deep into one of the most critical topics in cardiology, heart failure. Whether you are a student preparing for boards or a clinician looking for a refresher on the mechanics of decompensation, this clinical blueprint will walk you through everything from basic hemodynamics to advanced pharmacological interventions. Let's get started. To understand heart failure, we have to move past the idea that the heart has just stopped. Instead, think of it as a failure of supply and demand. It is the point where the heart simply cannot pump enough blood to meet the metabolic needs of the body's tissues. We analyze this through the core equation. Cardiac output is the product of stroke volume, how much blood leaves the left ventricle per beat, and heart rate. When one falls, the other must rise to compensate. We track this efficiency using the ejection fraction, EF gauge. A healthy heart typically ejects 50% to 70% of the blood sitting in the ventricle. If that number drops below 40%, we are officially in the territory of clinical heart failure. Keep in mind that a borderline zone exists between 40% and 50%, where patients may already be showing early signs of structural change. Now, not all heart failure looks the same. We generally categorize it into two distinct profiles. First, we have systolic failure, or HFrEF, heart failure with reduced ejection fraction. This is a pumping problem. The heart muscle becomes thin or scarred, often due to a myocardial infarction, and it lacks the squeeze needed to get blood out. On the other hand, we have diastolic failure, or HFpEF, heart failure with preserved ejection fraction. This is a filling problem. The ejection fraction might look normal, over 50%, but the heart muscle has become so stiff and thick from chronic hypertension that the total volume of blood the ventricle can hold is severely reduced. In both cases, the body is starved of oxygen, but the underlying mechanical defect is completely different. Why does a heart fail in the first place? A great way to remember the primary causes is the acronym FAILURE. F is for faulty valves. Whether they are narrowed, stenosis, or leaking, regurgitation, they force the heart to work twice as hard to move blood in the right direction. A stands for arrhythmias, like AFib, which can wear out the muscle over time. I is for infarction, where a heart attack leaves behind non-functional scar tissue. L is lineage, covering congenital defects and family history. U is uncontrolled hypertension, the silent driver of wall thickening. R represents recreational drugs, specifically cocaine and alcohol, which are toxic to the myocardium. And E represents evaders, viruses like myocarditis that attack the heart muscle directly. When the left side of the heart fails, the blood has nowhere to go but backward into the lungs. This creates a pulmonary backlog. To remember the symptoms, think of the patient drowning. They experience dyspnea, shortness of breath, and you will hear rales or crackles when listening to their lungs. They often have orthopnea, meaning they can't breathe while lying flat, and they might wake up gasping for air, a condition called paroxysmal nocturnal dyspnea. A key clinical pearl here: if the pressure in the pulmonary capillaries gets too high, they can rupture, leading to a nagging cough with pink, frothy sputum. Under a microscope, you'll see heart failure cells, macrophages that have literally eaten the leaked red blood cells. While the left side backs up into the lungs, the right side backs up into the body, causing a systemic backlog. We call these symptoms swelling. You'll see peripheral edema in the hands and legs, and you'll notice large neck veins, also known as jugular venous distension, JVD. Because fluid is backing up into the liver, the patient might develop hepatomegaly, or an increased abdominal girth, ascites. It's also common for these patients to experience nocturia, because when they lie down at night, all that fluid from their legs shifts back into the bloodstream and heads straight for the kidneys. Remember, the most common cause of right-sided failure is actually pre-existing left-sided failure. There's a fascinating clinical paradox called high-output heart failure. In this scenario, the heart is actually pumping out a massive amount of blood, but it still isn't enough. This happens when systemic vascular resistance, SVR, drops significantly. The pipes of the body's circulation are too dilated. This is usually triggered by conditions like sepsis, severe anemia, or hyperthyroidism. The heart tries to compensate by skyrocketing its rate and stroke volume, but because the blood is moving through the body too quickly, or the demand is too high, the tissues remain starved of oxygen. Why does heart failure get worse over time? It's because of a vicious cycle of compensation. When cardiac output drops, the body panics and activates the sympathetic nervous system, or SNS. It releases epinephrine and norepinephrine to make the heart beat faster and harder. Initially, the heart muscle bulks up, hypertrophy, to handle the load. But this comes at a high cost. Those overworked muscle cells demand more oxygen than they can get, leading to cell death. Think of the Frank Starling law like a rubber band. You can stretch it to increase the snap, contraction force. But if you overstretch it for too long, the band eventually loses its elasticity and snaps. That is the moment of decompensation. While the heart is struggling, the kidneys make things worse. When they sense low blood flow, they trigger the RAAS cascade. They release renin, which leads to the production of angiotensin II. Angiotensin II is a powerful vasoconstrictor. It narrows the vessels, which skyrockets the afterload, the pressure the heart has to pump against. Then, aldosterone and ADH are released, which force the body to hold on to sodium and water. This increases the preload, the fluid volume returning to the heart. The result? A failing heart is forced to pump against higher pressure while literally drowning in excess fluid that leaks into the lungs and tissues. Let's look closer at paroxysmal nocturnal dyspnea, PND. Why do these patients wake up terrified at 2 a.m.? It's a three-part storm. The fluid shift. When the patient lies flat, gravity no longer keeps fluid in the legs. That fluid rushes back to the heart, overflowing into pulmonary circulation. The sleep state. During sleep, the brain's respiratory center becomes less responsive, allowing fluid to build up before the brain realizes there's a problem. The adrenaline drop. Naturally, adrenaline levels drop at night, which relaxes the already weak heart muscle, further dropping cardiac output. The patient eventually wakes up gasping, feeling a sensation of suffocation. To catch heart failure, we use a diagnostic dashboard. Biomarkers. We measure BNP. This is a hormone released when the ventricles are overstretched. Levels over 300 pg milligrams suggest mild to moderate failure, while anything over 900 is a severe prognostic marker for mortality. Echocardiography. This is our gold standard for measuring ejection fraction and seeing if the valves are functioning correctly. Chest X-ray. Here we look for cardiomegaly, an enlarged heart shadow, and curly B lines, which are horizontal lines at the lung edges indicating fluid in the interstitial space. We stage heart failure using two different lenses, AHA stages and NYHA classes. The AHA stages, A through D, focus on the structural progression of the disease. Stage A is simply being high risk with no symptoms, while Stage D is advanced disease requiring specialized interventions. The NYHA classes, 1 through 4, focus on functional capability. Class 1 patients have no physical limitations, while Class 4 patients are symptomatic even at rest. A patient can move between NYHA classes as they get treated, but they generally only move forward through the AHA stages. Treating heart failure is about blocking the vicious cycles we discussed earlier. We use the ABAL regimen. ACE inhibitors or ARBs to stop angiotensin II, beta blockers to stop SNS toxicity, aldosterone antagonists to stop salt retention, loop diuretics like furosemide for immediate fluid offloading. Modern medicine has added powerful new tools, ARNIs like sacubitril valsartan, which promote vasodilation, and SGLT2 inhibitors, which force the kidneys to dump glucose and water, drastically reducing the heart's workload. These modern additions are now considered essential for reducing mortality. When medications aren't enough, we turn to advanced interventions. CRT is a specialized pacemaker that syncs the ventricles to boost the ejection fraction. VADs are mechanical pumps that can take over the left ventricle's entire job, often used as a bridge to transplant. In the worst-case scenario, the patient enters cardiogenic shock, where systemic perfusion fails entirely. This requires intensive IV inotropes like dobutamine and mechanical support like VA ECMO. The final, definitive option for end-stage failure is a heart transplant, indicated only when all other therapies have failed to halt the cycle of decompensation.
And that wraps up our deep dive into the heart failure clinical blueprint. I hope this detailed breakdown helps you in your studies and clinical practice. If you found this video helpful, please make sure to like this video, share it with your colleagues, and hit that subscribe button for CleanMedKE so you never miss an update. Thank you for watching, and we'll see you in the next one.